Welcome. In today's lecture, we'll be looking at the risk factors for Parkinson's disease. I think this question can be easily summarized as, will I get Parkinson's disease? That's a question that I get from my patients all the time, their families, and their children who are worried that the Parkinson's disease have run in their family, and what is the risk that they're going to get the disease. So let's have a look. My name is Danish Bahati. Today, I'm going to make you an expert on risk factors for Parkinson's disease and what causes Parkinson's disease. I'm sure you will find this valuable. I'm an assistant professor at the Department of Neurological Sciences and the co-director for Parkinson's Disease Clinic at University of Nebraska Medical Center. So this is my team. This is me right here, and I am standing with my team, including our case managers, my partners and mentors in Parkinson's disease, and our wonderful administrators. You can trust me. I will only tell you the truth and everything that is important. I want this to be informal. Together, we provide care to a large number of patients at the University of Nebraska Medical Center Movement Disorder Clinic. Just last year alone, we had more than 6,000 patient encounters. My disclosures: I have been speaking and doing teaching for Teva Neurosciences in the past and Acadia Pharmaceuticals currently in the drugs related to Parkinson's disease. I'm also doing a phase 4 study with AbbVie on Duopa and have research funding from them on it. I would like to dedicate this presentation to the memory of my father, who brought out the educator in me. He passed away earlier this year. He always encouraged me to teach and give back. It is important to ask this question: what causes Parkinson's disease? Will I get Parkinson's disease? This is important because 1 in 25 of us is going to get Parkinson's disease in our life. Actually, the ones who don't get it are just dying sooner than getting it. If you live long enough, you will get Parkinson's disease. At age 80, 20%, 1 in 5 of us who live to be that old are going to get Parkinson's disease. We don't have data after that, but who knows? What if it is like at age 100 or 110? What are our objectives? Our intention in this talk is meant to review what we will understand causes Parkinson's disease in the brain. We will learn how we tell someone has Parkinson's disease. We will review what increases the risk of developing Parkinson's disease. And the way we are going to achieve those objectives is by reviewing these following things over the next 30 minutes. We will look at Lewy bodies. How do we get them? What causes them in our brain? How do we diagnose Parkinson's disease? When do we know that there is Parkinson's disease? What is the prodromal stage of Parkinson's disease, and what are the markers that can tell us that Parkinson's disease have started, even though it is not fully clinically apparent? And most importantly, what is around us that make us have Parkinson's disease? And then there will be a picture quiz at the end to solidify the learning. So let's begin. How do we diagnose Parkinson's disease? When do we know someone has Parkinson's disease? We do it the same way we have been doing for a long time. We take a history and we perform an examination. A patient comes in with certain complaints that are commonly seen in people who turn out to have Parkinson's disease on brain autopsies, and we perform an examination to look for findings on exam that are consistent with Parkinson's disease as we know it. So this is one of the earliest illustrations by William Gowers, even before this disease was called Parkinson's disease by Dr. Charcot. It is from the Manual of Disease in 1886, and it classically described many of the features of a patient with Parkinson's disease. Let's look at a few of them. We see that the patient is slouching and is leaning forward. That's the bradykinesia or akinesia of the posture. Patient is having softer speech. That is the hypophonia or softness, again a sign of akinesia with Parkinson's disease. Patients have more rigid limb and akinetic limb, giving him bent postures or hyperflexion at joints. There would be tremor in the hands, especially when sitting or walking, and the handwriting will show the changes of akinesia. and so on and so forth. You can even notice that sometimes the legs are bent or knees are bent, and they are stooped and leaning forward and always trying to catch up their balance. But what is the gold standard for Parkinson's disease diagnosis? Is everyone who have some of these features going to have Parkinson's disease? How do we know for sure? When we look at the individual neurons in certain areas of the brain, they turn out to have certain changes in a patient with Parkinson's disease. So here is a neuron stained with a red dye at 1 in 1000 dilution, and that red dye is tagged to specifically stain alpha-synuclein in a neuron glia culture and then is being highlighted by immunofluorescence. The neuron has also been stained with a chicken polyclonal antibody to MAP2, which basically brings out the neuronal structure. And the red dye is staining some certain vesicular structures or dot-like structures in the pericardia and in the processes of neurons. So these are the red dots that I am talking about, and you see many dozens of them. These accumulations within the neurons have been identified as one of the markers and possibly a cause of Parkinson's disease. What are these accumulations? These accumulations were originally identified by Dr. Lewy and called Lewy bodies. So here is a neuron. You can see a cell body which is rounded like that. You can see a long tail of the neuron going out, and similarly a second one in the picture. You can see that there are melanin pigments which are staining reddish like iron content, and that's likely these neurons have to be those melanin containing neurons in the brain, which are not a lot. So these particular examples are from the substantia nigra, which gets its name of black substance because of these melanin in the neurons. And you see in one of the neuron there is this structure which has a pink dense core and is surrounded by kind of a lighter pink area around it, and then a halo around the lighter pink area. This specific characteristic of this body on the imaging is what we call Lewy bodies, and we see them accumulate in a significant amount in people with Parkinson's disease in the neurons in the substantia nigra and certain other parts of the brain. These Lewy bodies are formed of alpha-synuclein. The alpha-synuclein is present as a normal helix within the brain and has certain functions likely related to oxidative stress. These alpha-synuclein are usually present as short chains and are being degraded and recycled very frequently. Somehow the process breaks down in patients with Parkinson's disease, and these alpha-synuclein start accumulating and forming clumps, and these clumps can now not be removed, and they start forming these dense core bodies which were called Lewy bodies. So why do we get Lewy bodies? Why are the Lewy bodies being formed in the brain, which will end up causing death of those brain cells and Parkinson's disease? Maybe it's in the food we eat. Maybe it somehow has to be the environment. It's what we eat, what we breathe, what we do for living. There is some role of genetic factors, but so far, even with the best of studies, the role of genetics is considered to be less than 30%. Very few patients with Parkinson's disease have inherited Parkinson's disease, where a gene is directly causing Parkinson's disease, which is less than 5%. Another 25 to 30% have been identified to carry genes which make it more likely to get Parkinson's disease, but even they are getting the Parkinson's disease or Lewy bodies somehow started by the interaction with the environment. Maybe it's in the water that we drink. We know well water drinking, pesticide exposure, and other chemicals have been linked with increased incidence of Parkinson's disease through multiple epidemiological studies. Somehow, these environmental factors are resulting in the breakdown of the process of clearing debris from the cell, and in particular, the debris we're worried about is the alpha-synuclein. So we can see right here that there is a normal alpha-synuclein that is binding to the other proteins and tau proteins and microfibrils and is doing its normal job. So you can see that the Alpha-synuclein plays certain role in trafficking of the vesicle, proteasomal inhibition, and autophagy. But if that process breaks down and these oligomers accumulate into these large tangles, is when we're starting to have a breakdown of the process, somehow involving this enzyme called leucine-rich repeat kinase, and which result in mitochondrial dysfunction, causing the breakdown of the cell function. Well, when does Parkinson's disease start? If it's an environmental interaction, around what time does the Parkinson's disease happen? When the symptoms start, a few months before that, a year before that, a couple of years? Some of the information that we have now understood comes from work of the changes in brain in Parkinson's disease by Brock and Brock, who proposed Brock hypothesis of stages or pathological stages of progression of Parkinson's disease. What they found that if you look at the brain of a Parkinson's patient, the longer he has had Parkinson's disease, the more you find Lewy bodies in more and more increasing areas of the brain. Although some of these progression are not as smooth as shown in these pictures here, and have been challenged, but the basic concept still is considered true by most experts. So if you find a patient who have had Parkinson's disease and dies from it, is typically what is considered Brock stage 3. You see that the Parkinson's disease has already involved the brainstem right here where the substantia nigra is. And the process is starting to spread upward as noted by the arrows. And if you look at a patient at the late stage 5 and 6, you will see there is significant cortical involvement with the presence of Lewy bodies in cortical neurons. And that has been a strong association with the presence of dementia and presence of hallucination in Parkinson's disease, which are seen late in Parkinson's disease. And based on that, it has been hypothesized that maybe there are earlier stages called Brock stages 1 and 2 when the Lewy bodies are present only at the very bottom of the brain. The evidence for these stages 1 and 2 is much more flimsy, is more presumed, because although you can see Lewy bodies in a normal brain person, someone who has not been diagnosed with Parkinson's disease, there is no way to prove or say that if that person would have lived, he would have progressed the way as being hypothesized here and would have developed Parkinson's disease. But there seems to be a reasonable hypothesis at this point, especially given the progression between early Parkinson's disease and then late Parkinson's disease. Even more interesting is the extension of the spread to even beyond the brain itself. Rather than saying that the Parkinson's disease is starting down in the brainstem somehow and then spreading upwards, like we discussed in Brock hypothesis, there is now evidence and hypothesis put forward that the onset may even be in the gut. You know, it is shocking in some ways, but is also very plausible in some ways, as we have already discussed that it's very likely that Parkinson's disease is starting due to environmental factors in association. Then it's very likely that the most common location of that environmental interaction is in the gut. It's the food that we eat and things that we swallow. And somehow those changes in the gut are inducing Lewy bodies, and then that induced Lewy bodies are causing a change to go up into the brainstem through the vagus nerve, which supplies a lot of this GI tract and has origin or nuclei down in the brainstem. We know things like constipation starts 20 years before the onset of Parkinson's disease. We also know that if we look into the gut neurons of patients, we find the presence of alpha-synuclein staining Lewy bodies within the gut enteric plexus. The largest collection of dopamine producing neurons is actually in the gut. These dopamine producing neurons are part of the enteric nervous system and is involved in the gut peristalsis. So the same movement as the brain dopamine producing neurons are involved in the body movement. These dopamine containing neurons are shown to have Lewy bodies in a big percentage of population. There have been studies which looked at the gut biopsies for patients with Parkinson's disease done 10 years or 20 years before the diagnosis of Parkinson's disease, and a big number of them, anywhere from 30 to 50% of them, were shown to carry Lewy bodies in their gut 20 years before the diagnosis of their Parkinson's disease. So when does Parkinson's disease start? It is now starting to become very acceptable that the Parkinson's changes in the brain probably start 20 to 30 years before the diagnosis. And up to 10 years before the diagnosis, there might already be signs concerning for a potential of Parkinson's disease. So if you're going to get Parkinson's disease here, you may already be showing signs here, and you may already be starting to develop changes in your brain regarding Parkinson's disease right about here. Based on these information, we have started to classify Parkinson's disease in a new way. We now think of Parkinson's disease as the clinical Parkinson's disease, where there is a revised criteria on how to make the diagnosis, but it is still a motor diagnosis. Although non-motor features are increasingly recognized, they are not considered part of a diagnostic criteria because of the lack of accuracy. You will be overcalling Parkinson's disease in people if you start using non-motor features as a diagnostic criteria. But there is this condition now called prodromal Parkinson's disease, when the symptoms and signs which are suggestive or highly concerning for Parkinson's disease have developed, but there is not enough motor changes to make a formal diagnosis of Parkinson's disease. This stage may be a few years, this stage may be 10 years. And even before that, there is a hypothesized stage of preclinical Parkinson's disease when there is no apparent symptoms or signs, not even suggestive of Parkinson's disease, but changes of Lewy bodies have already started, likely in the brain, but maybe in the gut. What are those prodromal markers of Parkinson's disease? When should we suspect that the patient may be developing a Parkinson's disease? Remember, these are not diagnostic and they are not specific. They are not confirmatory. Some have a much higher risk of showing Parkinson's disease in the next couple of years, and some have much lower risk. So these are REM behavior disorder, which is the single most important marker of Parkinson's disease. The risk of having Parkinson's disease in the next couple of years who have had REM behavior disorder is 130 times more likely. We have loss of olfaction, a much less specific but still a very high risk factor for Parkinson's disease, constipation, and now the list is starting to becoming less and less specific, but still somewhat higher risk of Parkinson's disease. It will include dysautonomia, daytime somnolence, dopaminergic imaging deficits, other imaging markers, and pathological markers. All right, let's take a brain break here. This is my home saltwater aquarium, or as it used to be. It is being reset at this moment, but I have a lot of these things still with me. And we will shift the gears, and after building up the background that we just did, we will now start looking at what we know about the risk factors of Parkinson's disease. What are those risk factors that we will be reviewing? We'll be talking about age and sex, lifestyle, coffee and smoking, nutrition, rural living, environmental exposure, occupation, concomitant illness, and genetics. All right, let's look at some of the risk factors of Parkinson's disease. Age and sex. Let's talk about sex before. In a multi-center community-based study involving 8 Italian municipalities, a cohort consisting of 4,341 individuals aged 65 to 84, we found that among the Parkinson's patients, 68% of them were men and 32% were women. That brings it to about 2-to-1 ratio. Similar information has been found with other cohorts. So similarly, looking at this study, we found that the average annual incidence rate per 100,000 person years in the population of age 65 to 84 was 529 incidences for Parkinsonism and 326 incidences for Parkinson's disease. An incidence rate for both of them increased with age, both in men and women. Men had higher rates in every age group though, more than women, 2-to-1 as we talked about. And average age adjusted relative risk in men was compared to women was about 1.66 times more likely. So for every 1 year increase in age above age 65, remember the cohort is from 65 to 84, there was a 0.09 times more increase in the risk of Parkinson's disease, or 0.1 for Parkinsonism of all cause and 0.1 for Parkinson's disease, with a range. And as we discussed before, male gender was 1.66 times more likely on average at any given age than women to get Parkinson's, and it was Parkinsonism of all cause, and 2 times more likely, 2.1 times actually, to develop Parkinson's disease. We also found that there is a significant difference in the incidence of Parkinson's disease in people who exercise versus who don't exercise. It doesn't matter what kind of exercise, any form of physical exercise is reasonable. In the same population, if we look at the proportion of people who were exercising over 2 hours daily, their risk of developing Parkinson's disease were down to 69% compared to people who were not exercising for more than 2 hours over a week. So their incidence was close to 83%. So although they also had some protection from some exercise, not as good as people who were exercising more than 2 hours on a week. Exercise, as I said, could be anything. Could be walking, jogging, dancing, swimming, playing ping pong, and performing Tai Chi. All of them was labeled exercises for this 2 hour a week calculation. So any exercise is fine as long as it's moving the body. And when we look at the different types of physical activity and we evaluate physical activity in Parkinson's disease patient, in the NIH Diet and Health Study cohort, which is 213,000 participants, and we look at physical activities divided in age groups. If we look at the age group of 15 to 18, 19 to 29, and 35 to 39, and also look at the exercise done in the last 10 years. So let's say if they're 65, then from 55 to 65. If they're 60, then from 50 to 60. So if we look at these two numbers, exercise done in age 35 to 39, exercise done in past 10 years, we note that there is a significant correlation between exercise and lowering risk of Parkinson's disease. Exercise in last 10 years was useful, but exercise done in age 35 to 39 was way more significant to reduce the risk of Parkinson's disease. And that makes sense because we have discussed before that Parkinson's disease may be starting up to 20 years before the diagnosis. And that's why exercising when the Parkinson's may be starting have a far larger impact than having exercise done in the last 10 years. We also note that reading is an independent factor protecting against Parkinson's disease, and a significantly greater amount of reading was observed in people who don't have Parkinson's disease. So 90% of them were reading frequently compared to people with Parkinson's disease where only 80% were reading, which is still a big number, but a clearly significantly different number. So people who don't have Parkinson's disease tend to be better readers than the ones on average in the group as compared to the people with Parkinson's disease. And the question is raised, is it a cause or is it an effect? A chicken on the egg problem. Is it that those who don't exercise and don't read are getting Parkinson's disease? Or is it that the people who are starting to get Parkinson's disease are not exercising as much or not reading as much as the others? That somehow there is an impact on their habit or decision making because of the changes going on in the brain that make them change their personality or make a different decision. Remember, they haven't had Parkinson's disease enough symptomatically to be diagnosed and thus should not be directly affecting their exercise due to physical limitation. Let's look at lifestyle and smoking, another important factor. In 61 case control studies and 8 large cohort studies, if we pool them together, the relative risk of Parkinson's disease was way lower, 40% less likely to develop Parkinson's disease in people who were ever smokers compared to people who never smoked. We also noted that for every 10 pack years, the chance of developing Parkinson's disease goes down by 20% based on the pooled relative risk analysis of 61 case control and 8 cohort studies. So if you've been smoker and if you've been smoker for 10 pack years, you're 20% less likely to be in the group of people who get Parkinson's disease than to be in the group who don't get Parkinson's disease. What is the cause? Does smoking protect from Parkinson's disease, or are the smokers just dying younger? Remember, we talked about it. Parkinson's disease will happen if you live long enough. Is it that the people who are developing Parkinson's disease that starts 20 to 30 years before the diagnosis, they just make a habit change. They don't smoke because of the changes that are going on in their brain. Hong et al. Investigated the effects of nicotine and other 4 compounds of cigarette smoking, anabasine, cotinine, hydroquinone, and nomicotine, on the fibrillation of the alpha-synuclein protein which aggregates in the Lewy bodies of patients with Parkinson's disease. Nicotine and hydroquinone did inhibit formation of alpha-synuclein fibrils, while nicotine being more effective, indicating that these compounds can stabilize soluble oligomers or small chains of alpha-synuclein and thus preventing formation of large clumps which form Lewy bodies. And maybe there is a neuroprotective role of these chemicals which are found in smoking. Another interesting phenomena that is being explored now is the impact of smoking on the gut microbes, which we will be taking on later in big details. Let's look at this question again. Why does smoking help prevent Parkinson's disease? Is it that the effects of smoking and alcohol and coffee consumption that we'll look at next suggest that there are markers of another underlying risk factor? So is there a secondary association, something else is going on that is making you more likely to have smoking, or smoking is causing a change in something else which lowers your risk of Parkinson's disease? There is another hypothesis called premorbid personality hypothesis. The hypothesis is that the individuals who are predisposed to developing Parkinson's disease have a specific personality, premorbidly, meaning that way before they develop Parkinson's disease, that manifests early in life, and this personality leads them to avoid the use of substances that causes dependence or have negative sanctions from societies or jeopardize health, such as tobacco, alcohol, and coffee. So these people have a personality where they're moralistic, they're law-abiding, they're conscientious, they're orderly, and they're cautious. We see it all the time in people who are presenting to clinic with Parkinson's disease. These people always follow the instructions, they take their medications on time, they're always on time for their appointment or early, they're always very polite and apologetic. And actually, few patients who have young onset PD behave very differently. So there is a postulation that this personality leads them to refrain from extreme behaviors such as substance abuse and smoking. And these are the people who are going to develop Parkinson's disease lately. So it's the same, it's the underlying personality of Parkinson's that is making them not smoke, and it's not that the smoke is protective. So So, as hinted before, coffee drinking has also been shown to significantly reduce the risk of developing Parkinson's disease as much as 31%. The magnitude of association remains unchanged after adjusting for education, for socioeconomic status, for other health problems, and the number of cups per day has a linear correlation for protection. So the more coffee you drink, the more likely you are to be protected and less likely you are to end up being in the group who develop Parkinson's disease. Coffee drinking and smoking are often present in the same subjects. 48% of all cases in control subjects both drink coffee and smoke. However, even for controlling for smoking, coffee drinking remains independently significantly associated with Parkinson's disease in itself. And not only that, another interesting phenomenon reported is that people who develop Parkinson's disease, if you divide them into people who did drink coffee and the ones who did not drink coffee, you find that the people who were drinking coffee develop Parkinson's disease at a much later age, and median age of 72 years, compared with Parkinson's people who never drink coffee, who develop Parkinson's disease at a mean age of 64. What are other nutrition factors that may be related to Parkinson's disease? And a bunch of them have been looked at. There are hints of protection from omega-3 vitamins, from vegetables, from fruits, from carotenoids. And we talked about caffeine and coffee and tea. There are many compounds that are found to be neutral to the best of evidence so far, like vitamin C and riboflavin. And there is one single nutrient that has shown to have a clear association with a higher risk of Parkinson's disease in multiple studies, and that's milk. So what's wrong with milk? Results of meta-analysis of data from all prospective studies on dairy products, milk consumption, and risk of Parkinson's disease in men and women show clearly beyond doubt that there is a higher risk of Parkinson's disease in people who were milk consumers. So the data from Honolulu Asia Aging Study, HAAS, from Nurses Cohort Studies, from Health Protection Study of NIH, found increased risk. And if you pool the data together, there is a 60% increase in risk of being in Parkinson's group if you were a milk drinker. So what's wrong with milk? There are many theories put forward. It may be contaminated with the neurotoxins of pesticides. We know we're getting a dairy milk from out in the rural areas, the same areas which have higher Parkinson's from pesticides and well water drinkings and other chemicals. It may be there are inherent chemicals within milk that may be causing Parkinson. But one of the most interesting hypotheses that we have once hinted before is the association of milk with the gut microbias, and in turn relationship with the serum uric acid level. We know that the milk drinking have an effect on circulating uric acid. A lower circulating uric acid and lower risk of gout is seen in people who are milk drinker, and a lower uric acid level has been linked with a higher risk of Parkinson's disease, and gut microbes can impact the amount or absorption of the chemicals that get turned into uric acid in the blood and thus control serum uric acid level. We will rediscuss this in the gut microbes later on. What is the gut microbial association with Parkinson's disease? It is significant. 1 to 2 kilograms of bacteria live in the gut in all of us. These are 10 times more cells than human cells in the gut. So it's a significant amount of live biological filter that we have in our gut. Gut microbes in Parkinson's disease are altered. Many studies have proven beyond doubt that people with Parkinson's disease on average have a different mix of gut microbes than humans without Parkinson's. Prevotella enterotype, which produce high amounts of anti-inflammatory fatty acid, which likely influences colonic uric acid levels, have different amounts in people with Parkinson's and without Parkinson's. Smoking and coffee have a direct effect on gut microbes, causing expansion of that Prevotella bacteroides species. Diet rich in fiber, fruit, and vegetables also affect gut microbes and may be the reason why they show some certain protective benefits against Parkinson's. So there is this final common pathway hypothesis that gut microbes seems to be the binding factor or link between various other factors such as milk consumption, coffee, smoking, serum uric acid level, alteration in gut barriers, start in the gut. We know that that gut microbes have changed in Parkinson's, and one of the strongest indications or proof comes from these studies of gut dysbiosis. If we use indican as a marker for certain bacteria or microbes presence in the gut, so the way it's used is that they get a capsule with a certain amount of uh, the precursor to indican. That precursor has to be metabolized or digested by the gut microbes to be absorbed in as an indican. And if the number of those bacteria is high, then more indican is being absorbed, and the number is low, then less indican is being absorbed. And then those indican dye are being peed out in the urine, and you measure the urinary excretion of indican or urinary indican concentration. And if you look at people with control, you will see a significantly less excretion of indican or less absorption of indican, and this absorption go up in people with Parkinson's disease. And that shows that they have more number of bacteria that can process indican. This difference is also affected by dairy milk intake. Other risk factors that have been elaborated are rural living and environmental exposure. Prospective studies on the association between components of metabolic syndrome and incidence of Parkinson's disease have shown there are inconsistent results for other conditions like hypertension, serum total cholesterol, diabetes, obesity, but the jury is still out on most of those associations. This is a study from Nebraska. This study was a very crafty study using the data from registries. There is a strong data tracking for a lot of information in United States. So in state of Nebraska, any purchase of pesticide or insecticide for farming use is registered with the Central Farming Registry, and that data is recorded as a data based on counties. So this is the map of agricultural map of Nebraska, where you're seeing the land which is irrigated and is being used for agriculture, and down to the farming level. Here is Omaha, where I live, and here's the Lincoln, the capital of Nebraska, and you can see the spread of the whole green farming communities. There is data available for pesticide use in those farming communities that is not as granular as the previous data, but can be broken down into counties. So each square that you see is a county. The counties are of different size based on population. Certain areas are less dense, less people, so the counties are much larger and bigger. Some areas are more dense, and the counties are then much more smaller in size. And you can see that certain counties are using the pesticides far more than the other counties, and you have that information. Similarly, you have information available from the Parkinson's registry in Nebraska about the incidence of Parkinson's disease in various counties. Registry of Parkinson's disease in Nebraska is a state mandated registry through legislation, which means that the law requires every newly diagnosed Parkinson's disease case to be registered with a state registry being maintained in the Department of Health. That reporting is done by physicians, by dispensaries, pharmacies, nurse practitioners, nurses, pharmacists, any source that can give that information to the state. And we have data on 14,000 or more patients who have been registered with Parkinson's disease registry since the onset. Now that information is stored also at county level, and if you overlap the counties which have higher incidence of Parkinson's disease, you find that there are two big hot zones in Nebraska, one right here and one right here. And then you also try to correlate these hot zones with the use of pesticide and insecticide, and you find that there is some overlap. there is not a full direct one-to-one overlap correlation. There are some other factors that are influencing the distribution, but there is clearly an impact of increased pesticide use on increased incidence of Parkinson's disease in those hot zones. So studies have not been conclusive about pesticide association with Parkinson's disease. Why is that? There are many reasons. Studies were inadequately designed. Maybe they didn't knew how to pick up Parkinson's disease well, or how to pick up different factors in association. They were underpowered with few exposed individuals or few diagnosed people. They are not population based, meaning that there are small number of people being studied, not a whole state or a whole country being studied. They fail to distinguish between incidence of Parkinson's versus prevalent of Parkinson's, and they relied on multiple comparisons or prior available data such as through government databases and not a direct prospective study. Therefore, the results across the studies are inconsistent. For every study that is positive showing an association of pesticide with Parkinson's, there is another study showing no relationship between pesticide and Parkinson's. All right, and here comes the picture quiz. What are the stuff in the brain that causes Parkinson's disease? That's correct. Lewy bodies, pointed out right here on a hyaline stain, and they should stain for alpha-synuclein. When does Parkinson's disease start? That is correct. 10 to 20 years before the diagnosis of Parkinson's disease. Who gets Parkinson's disease more, men or women? That's right. Men are almost 2 times more likely to get Parkinson's disease compared to women. Does exercise help? Definitely. Exercise reduces the incidence of Parkinson's disease down to 69% compared to 83% in people who do not exercise. And what is the final common pathway linking all the different risk factors for the diagnosis of Parkinson's disease? That's correct. The gut microbes. It's what we eat, what we drink, and what we breathe. All right, let's have another cup of coffee and protect ourselves from Parkinson's disease. But remember, don't add milk. And here's our attempt at high note closure, stuff that really matters. Work hard and love your work. Say yes, maybe a little more than you say no. Thank you.